On this special edition of This is America and the World, we've gathered together 4 physicians, all experts in the fields of alcohol and drug addiction. They're here to discuss the American epidemic of opioid drug abuse and overdose deaths. This epidemic has caused America to refocus its attention on its number one health problem, alcoholism and drug addiction. This is America and the World. Dr. Baxter, as we were coming on the air, you were saying that in New Jersey, where you're coming down from, thank you very much for coming down, that the governor knows somebody who maybe has an addiction problem, and that changes the whole complexion of how politicians look at addictions, huh?
Absolutely, and we find that whenever there is a champion, we can get more done, and we can have more understanding occur. The governor has openly spoke about his relationship with a childhood friend, I believe, certainly college, and I understand that this individual was someone that he held very closely. And so the governor had the first-hand opportunity to look at what addictions can do, and he looked at how people can get well. Mm-hmm. And as I understand it, his friend did get well and stayed well for many years.
Let me, headline in a article that appeared in the Boston Globe, Overdose Kills Kin of UMass President. And it goes on to say that the nephew of the president of UMass died of a drug overdose. And we're talking about opioid addiction. 23,000 deaths in the last year. Dr. Stoller, weigh in on that, huh?
I don't think that anybody can say at this point that they haven't been personally affected or know somebody who has not been personally affected by this. Every day there's over 100 people that are dying from this, and about half of them through pain medication overdoses. Mm-hmm. This is crossing all lines of society, all regions, all socioeconomic areas, and it's something that we need to finally address as a people.
Dr. Olsen, would you say epidemic is the right word?
I think that probably is the right word. I mean, this is not a new problem. I do think that we have seen an increase in the rates of opiate use disorder or opioid addiction, treatment admissions over the past 10 years or so. And I think as Dr. Stoller mentioned, much of that has been related to the increase in opioid prescribing for chronic pain. And so we know that it also now has been seen, this addiction and overdoses, in demographic areas, in geographic areas that really didn't have this problem before. For example, in Maryland, I just learned last week that there's a very small county kind of on the western part of the state that for years and years and years, alcohol was their problem. And in the last 5 years or so, they've seen a shift from alcohol to opioids and now to heroin.
Let me take advantage of Dr. Mendenhall. When you and I talked over the weekend, and we talked about opioids, there's good news about opioids, right?
Yes,
As
Dennis.
far as a classification of drugs?
As a classification of drugs, these are very useful. But what's unfortunately happened over the last 20 years is that the original utility was misadvertised to physicians, meaning these are very useful drugs for relieving suffering at the end of life and for relieving suffering around significant procedures like surgeries. But there was a belief based on some spurious science that these medicines would be safe to give to people over the long term. And we've seen a shift. I began training right about the time the shift happened in the mid-1990s. And unfortunately, it became, if you will, okay for physicians to prescribe. Then it became an expectation that physicians in primary care settings in particular would prescribe these medications to individuals with pain issues. And unfortunately, I would argue that our industry as a whole, our profession as a whole, really didn't have a good understanding of how we were changing people and how that was ultimately going to lead to societal changes that I think we're now seeing in the face of this epidemic.
And I think, I also remember being in training kind of in the 90s.
How much training did you have when you came up in your early years in medical school? How much in addictions?
Very little.
Very
Probably
little? How much?
Couple of hours.
Couple of hours,
in my
Dr. Stoller? How
psychiatry
much?
rotation.
Maybe a few hours.
Few hours, Dr. Baxter?
I trained in the 70s, and we only talked about alcohol during pathology.
And Dr. Mendenhall?
Dennis, 3 hours.
3 hours.
No more than 3 hours.
That was it. So that was the training of in the addiction medicine field, which is now a whole new area of medicine, huh? Is that a fair statement to say? Go
And
ahead.
Dennis, it's getting better. That's the good news. So this week, actually starting tomorrow at Johns Hopkins, there is a 3-day intensive course for all of the second-year medical students. And we'll be bringing in actually 30 or 40 patients from my program so that they can learn how to take a good substance use history and how to interact with people with these issues in a way that's respectful, in a way that encourages people to talk about their problems.
Okay, so we've established that the opioids are good medicine in certain situations. The doctors are prescribing them, well-intentioned, I'm sure. What are some of the drugs we're talking about that folks at home or even physicians would be familiar with? Is it oxycodone, Vicodin?
Yes.
What else?
Yes, Percocet.
Percocet, So these are regularly prescribed drugs. So let's take a little break. When we come back on the other side, we want to talk about warning signs that physicians, maybe family members, and patients themselves should be aware of. Take a little break. This is America and the World. This is America and the World is brought to you by the National Education Association, the U.S.-China Education Trust, and F.Y. Chang Foundation, guided by Ambassador Julia Chang Block, President. The League of Arab States, representing 350 million people in 22 member countries. Japan, history, hospitality, and advanced technology. Sharing tomorrow. Tourism, Malaysia. The Petroleum Group, expertise with integrity in the fields of oil and gas, exploration and production, energy, and infrastructure. The Rotondaro Family Trust. The Embassy Series, uniting people through musical diplomacy, presenting international artists in diplomatic settings. And Ventana Productions, television facilities, editing, and distribution services. Doctor, you're all set to go. Jump in.
Dennis, one of the things that I've learned through my mentorship and from my patients is that probably the most important warning for patients and families is that if this medicine makes you feel better than this medicine really should, I want you to pay attention. And we know that if people experience euphoria or reinforcement, we call that reward in the addictionology field, then we know that something is afoot. We know that this is a medicine that a person might move away from taking for their post-operative pain, let's say after a cesarean delivery or a hip replacement, and move towards treating symptoms of anxiety or depression.
So let's say we got some physicians watching this program, and I hope they do, and I think they will. What should they be on the lookout? What are the warning signs for a physician that a patient has crossed that line that Dr. Mendenhall has just put on the table, and now they're looking for something else, huh?
Yes, well, even before we get to that point,
go ahead.
I think that physicians need to take time to evaluate a person's family history and their own history of having problems with alcohol and other substances. Certainly, there are millions of prescriptions written for opiate pain medications, but only maybe 9% end up having problematic use. So I think that the very first thing that physicians need to do is to fully evaluate a patient's past medical history and their family history for addiction.
Crucial. Is there some kind of a registry that doctors can go to that tells what other doctors have been prescribing? Is that's important for the physician, isn't it?
Yes, almost all the states now have a prescription drug monitoring program, a PDMP, and it is a database that physicians can sign on to find out where the patient is getting prescriptions for opiates, or in some states other sorts of potentially abusable medications. In some states it's actually starting to be required that the PDMP is to be consulted before somebody writes a prescription for an opiate.
Oh, that's a big one, isn't it? That's a big one.
And there also are now efforts, particularly in states where they are surrounded by other states that have their own PDMPs, to actually do inter-state PDMPs. So for example, if you're in Pennsylvania and you're on the border of Pennsylvania and Maryland, you go into Maryland or you go to Delaware and get your prescription filled, that information now is actually available to physicians in Maryland or in Pennsylvania, so that you really can actually, it's not just by state, it's almost kind of regional.
Years ago, when I was in the business of alcohol and drugs, and I'm proud to say that I'm long-term recovering from both, I would doctor shop. That's the phrase that people use, right? Doctor shop. Going to somebody in Michigan as well as somebody in New York and getting more prescription. And quite often it's the opioid plus some kind of a tranquilizer or anxiety medication. Is that it?
Yes, that's what is potentially very fatal if those medications are taken in combination. So it is important that those sorts of medications would be tracked through the PDMP and elsewhere.
Any other thing? Doctor,
Yes.
go ahead.
Yes, well, I was
Dr.
going
Doctor.
to add that when we talk about opiate overdose cases, very rarely are they just purely due to opiates. It's the combination of opiates and benzodiazepines and alcohol.
Go ahead.
And that, well, as a psychiatrist, it also speaks to me in terms of the co-occurring disorders, be it pain and psychiatric problems, depression, other sorts of issues like that. Those disorders need to be screened for and treated appropriately.
Do the drugs kill physical pain, or is it some kind of a reaction in the brain that blocks the pain, or how do these opioids work?
So they work on, we're all born with an innate opioid receptor system that we have to help modulate pain, so kind of to help us react to pain, particularly acute pain when it happens. Unfortunately, there are some instances in which patients will develop kind of chronic pain, and that's where some of the challenges have been, because chronic pain can last for several months. It doesn't have a productive purpose, and so the opioids that were really pushed heavily 20 years ago, that was really the population of individuals for whom the pharmaceutical companies said, oh, this is really fabulous, and you as a provider and as a primary care provider, don't have any qualms about writing that prescription. But we know that, chronic pain, there are many different neurocircuits in the brain that get affected, and that for some people may actually be affected even before they develop the addiction. And which is why some of the family history and the personal history is really important to know about trauma, histories of trauma, because there is some evidence now that trauma can actually influence the development of the brain in young kids and as they get older. So, and putting them at risk for then significant issues with opioids or other substances as they grow up.
Completely agree with Dr. Olsen, and I think it's important to characterize that anyone that takes these medications for even a period of a couple of weeks will develop some physiologic dependency, meaning if they cease taking these medications, they are going to potentially have a withdrawal experience. Now, that propagates over time, and as people become more tolerant to medications, the history over the past 20 years has been physicians prescribe more and more medication, which creates an exceptional amount of risk. We know that, as Dr. Baxter was saying earlier, a small percentage of people truly develop addictive disease. But we also know that somewhere between 40 and 60% of patients who take opioids chronically will begin the process of misusing them or abusing them. They will start down that slippery slope, and a lot of that has to do with how the receptor systems that Dr. Olsen was talking about are changed over time, and how the neurotransmitter dopamine is downregulated. Different receptors are downregulated, and in certain circumstances there's evidence that the drugs themselves may cause neural inflammation and change the actual wiring of the midbrain.
Dr. Stoller, when you and I were chit-chatting before the program, you were giving some of the other warning signs that people should be on the lookout for, whether it's physicians, whether it's patients themselves. We mentioned doctor shopping. What would be some other things that you would want to add into the conversation here, warning signals?
Well, certainly if the patient is running out of their medication before they're supposed to, that would be another warning sign.
Before they're supposed to.
Correct.
Okay, so it's legitimately prescribed, but they're running.
Right.
They find themselves running out. Go ahead.
And certainly if the medication that's being prescribed doesn't seem to be effective. And what I use for a measure of effectiveness is the person's functionality improving? That's what it has to be. For a lot of chronic pain patients, it's not really realistic to use a pain-free state as what we're shooting for.
Okay.
But if the functionality is increasing, then that's good. If the person seems to not be functioning better, and certainly if they're functioning in a less functional way, then that would be a warning sign. The other thing I have to bring up that's very important is that of people who are abusing prescription pain medications, they get that medication over half the time free from either a family member or a friend. So it's very important for a physician to prescribe measured doses when they do need to prescribe.
Right.
So something I read say you get a wisdom tooth out, maybe you should have some kind of medication for 3 days, and the doctor writes a prescription for 30 days. Well, you're going to be off to the races if you continue to use that.
Right.
Huh?
And part of it, I think, is also, so the American Society of Addiction Medicine and others have really, characterized addiction as, and people who are kind of start to develop suggestions and hints that they might be getting a problem as loss of control. So people really they develop a craving, this unbelievable kind of urge that won't stop, that just kind of this compulsive need. And I think it's important for physicians as well as patients and family members to really understand the difference between the physical dependence and the addiction, because physical dependence, as was mentioned, that is an expected response and an expected adaptation of the body to opioids. It doesn't happen just to opioids. It happens to many different classes of medications, including benzodiazepines, steroids, some antidepressants. So that when you do then either stop abruptly or cut the dose very significantly, people will then develop a withdrawal syndrome. The addiction is really that kind of compulsion and that craving, and I will do anything and everything and things I never imagined myself, and those behaviors that really accompany kind of that craving.
So that's like definition of addiction, right? A kind of a mental and physical craving or needing or wanting the drug, be it alcohol or be it any of the drugs
and then
we're
the
talking
behaviors
about.
that go along with it,
Yeah.
so that people then also try and cut down and they can't. The whole kind of you can just stop using. That's not realistic for somebody who has an addiction, because they would love to be able to stop.
Yeah, just say
and they
no
can't.
is not. And
work.
how many times
Right.
do you say?
Right.
Go ahead, Dr. Baxter.
Yeah, we also have to realize that when we're looking at this whole problem of opiate addiction and dependence, that we don't overshoot, because there are real phenomena such as the development of tolerance. So if a patient says this doesn't work well as it used to, then we should not automatically assume that they're misusing or abusing. It may actually be tolerance. And in some instances, we have the phenomenon of hyperalgesia that occurs with chronic use of
What is that?
opiates.
What is that?
Well, where the more opiate that you give, the more pain that the patient feels. And so what happens is that many practitioners will continue to increase the dose, and as they do, the patient saying, this is not working, the pain is worse, it's worse, it's worse. And that will lead for us to have difficulty in terms of managing this patient.
So that would be very sophisticated for the doctor to know what's going on there, huh?
Yes, and
Or to make a judgment as to what's going on.
yes, but to be aware that something is happening and to make that referral to an addiction medicine specialist.
Doctor?
I think it's really important to recognize that for that person that has become therapeutically dependent on opioids, if they suddenly have their opioids discontinued or they run out early, they're going to look a lot like a person who has addiction because they're going to have a really severe withdrawal syndrome.
Now, you've just put on the table, how does this thing happen that, let me ask a couple of quick questions. What's the profile of somebody coming into treatment that you see?
Typically somebody that has lost control over their use of medication and has become, to a certain degree, powerless over their compulsion. And we see that in terms of behavior.
But give me a real person. What kind of a real person would show up in treatment?
Let's say a
What's her-
54-year-old executive. A good example would be a 54-year-old executive who has had a bad back for several years from degenerative disc and facet disease, so
Okay.
arthritis of the back, who got started on opioids maybe 5 or 6 years ago and then has had a couple of back surgeries, but the opioids were never discontinued. And we know that unfortunately opioids themselves for chronic pain are a grade C recommendation.
So what percentage of people who are showing up in a treatment center have, like in my day, it was pretty much alcohol, and then you kick it up 20 years, and it's, for younger people, it was alcohol and some kind of medications. But now, what percentage coming in for opioid addiction?
Within the Hazelden Betty Ford system, we've seen over the last 12 years an increase of opioid use disorders as the primary diagnosis in our adult
Primary diagnosis. The primary. You're all shaking your head.
Well, so I work in a setting where that's really the primary diagnosis that we take care of. So, but I think kind of back to the other point that about 75% of the patients that we see also have other substance use disorders. So, opiates, alcohol, cocaine, marijuana, benzodiazepines, many other psychiatric diagnoses, and a lot of medical conditions.
So what's your experience, excuse me, Dr. Stoller, the people you're seeing?
Yes, very much multiple medications, multiple drugs, as Dr. Olsen said. In fact, for people who are misusing prescription opiates, they're about 40 times more likely to use heroin. And that's the other issue, is that we need not only to educate.
Say that sentence again.
They're about 40 times more likely to use heroin.
How does a person get from the executive that you mentioned to heroin, and how do they get there, and where do they buy it, and how do they use it, and so on and so forth?
That's
Well,
Go ahead, both
I was
of
just
you.
going to say, part of it is related to what are physicians taught. Now, are they taught how to prescribe and what to notice in terms of warning signs? But also, I don't think that they're being taught how do you interact with the patients.
How do you treat?
Well, how do you interact? So at the
Interact.
time that a physician writes a prescription, there should be a conversation about the potential risks, like in any medication that we write. And then what to look for and what would be done. So the mistakes would be to say very few people develop any problem with this, 1 in 10, 1 in 100. So it's very unlikely this will happen, and then stop the conversation there, because then if the person develops something, they'll think that they're so unordinary that they don't want to
Dr.
admit that.
Baxter, yeah.
But once that the person becomes dependent or addicted, and their tolerance increases and they need more and more money, they're going to get cut off by the doctor who is using the prescription drug monitoring program and sees that he has multiple doctors prescribing. And then they go to heroin because heroin is cheaper.
Where do they get it? Where do they buy it? How do they come by it? Do they inject it? Is it pill or what?
They can do it in a number of different ways. Back in our time, I'll say our time because you seem to be with me.
Oh, I'm very public as being a recovering alcoholic. Yep.
Okay. Well, nobody wanted to use needles, but the heroin is so pure now that you don't have to. So that is one stumbling block that is no longer operative. But it can be snorted, it can be smoked. And believe me, those people that are in need of finding heroin to replace their pill opiate dependence, they know where to get it.
In fact, Dr. Baxter, there have been twice as many heroin overdoses, as you know, over the past decade, and there's been this shift. I think that physicians need to be able to make recommendations about ongoing treatment as opposed to simply cutting off.
And I
their
think also
supply.
really understanding where their colleagues are in addiction medicine.
For immediate help or more information, call this national helpline, 1-800-662-HELP, 1-800-662-4357. For information about This Is America and the World and to watch all of our programs, visit our website, thisisamerica.net, and look for us on Facebook and Twitter. This is America and the World is brought to you by the National Education Association, the U.S.-China Education Trust, and F.Y. Chang Foundation, guided by Ambassador Julia Chang Block, President. The League of Arab States, representing 350 million people in 22 member countries. Japan, history, hospitality, and advanced technology. Sharing tomorrow. Tourism, Malaysia. The Petrolin Group, expertise with integrity in the fields of oil and gas, exploration and production, energy, and infrastructure. The Rotondaro Family Trust. The Embassy Series, uniting people through musical diplomacy, presenting international artists in diplomatic settings. And Ventana Productions, television facilities, editing, and distribution services.